So the title itself, what does it say? Ethical issues in end-of-life care. Okay, so whenever you think about end-of-life care, ethical issues become part and parcel of it. There's no end-of-life care without ethical issues. So what are going to be our learning objective for today? Main things are, we will discuss the transitions in an illness trajectory of life-limiting illnesses. Next, explain the principles of biomedical ethics and their application in end-of-life care. That's what I was trying to explain in the beginning, because they both work hand in hand. Next, explain the existing legal provisions and national level policies that facilitate end-of-life care provision. Finally, discuss concepts like the limitation of life-sustaining treatment, do not attempt resuscitation, futility of care, withholding or withdrawing treatment, and also advanced care planning. See, the last things, whatever has been mentioned, they may all look big terms, but if you understand what they are, and that's what we will be doing through our session today, to make things easy and comfortable for all of you to deal with them. Next comes, what is this transition in chronic illnesses? See, like I will just give a comparison to, all of us are born, we grow, become like children, adolescent, adult, elderly. So like that, even the disease trajectory has various phases. For example, as long as someone is hale and healthy, nothing is thought about. Once some form of illness comes in, the first element is diagnosis. What is it? What is going wrong? So that is the first part, that is, which comprises with investigations, seeing physicians, having sufficient and appropriate tests to find out what the issue is. Next comes whether with the disease, whether normal functioning is happening or not. Sometimes this state may vary. The disease progress or process may be a short one affecting everything, or it might be a gradual deterioration. So that's what is expressed in the next phase, called as decompensation. Sometimes the body copes. It copes to an extent where till it can. Then decompensation is when the body is unable to cope and manage or maintain normal existence. That is when the symptom may be in exacerbation, and also functionality may deteriorate, bringing in dependence also along with it. And then finally, the last two phases will be when decompensation has gone to an extent where the system is unable to cope. That is what is decline and terminal illness and death and bereavement, those two. So if you see in the bottom of the same slide, you've got diagnosis and palliative care. And the the red one is the time progress. That's what which I've mentioned. And through this few sessions, you would have known that palliative care co-works or works along with the other form of curative care also, which you would have all seen that initially the percentage observed or covered by curative care may be more, the palliative care component may be less. As time progresses, if curative care is going on in a better way with remission or progress, betterment in the disease, the percentage covered by curative care will be more and palliative care will be less. But as the disease progresses or there is no response to treatment, then the curative element decreases and the palliative element increases. That is what is the general trajectory of the palliative care and curative care. Next slide, please. Generally, this next one is what generally or overall, this is the projected forms of trajectories of dying. See, all these four have a great role. So I would say one of the important things in today's session would be to understand these 4 various types of trajectories which are given. I will explain in detail all the 4 because this is what is going to help you to know how each type of disease can progress. So the first one is sudden death. In this, only 7 to 10% of the population can have this form of trajectory at the time of death. Mostly like accident, sudden massive myocardial infarction or cardiovascular collapse, which is what will come under this heading. As I mentioned, only 7 to 10% of the population can have this type of end. The next one is terminal illness. In this category, malignancy or any form of cancer can fit into this category, which is said to be 15 to 20%. If you see the graphical representation, the person could be able to maintain his normal life, or if his functionality was very high, they could carry on being like that even when they age. But what happens is, suddenly once the diagnosis is made, there is massive deterioration. This is called as a waterfall effect. If you see the diagrammatic representation is also like a waterfall from what level of functionality to what level it comes down. As I said, cancer is one of the common disease which takes this trajectory. And the percentage which could go in this would be 15 to 20%. Then the third one, which is organ failure, is one in which nearly 50 to 60% of the population will come into this trajectory. If you see in this trajectory, the functionality itself, if you compare 1 and 2 with 3, see the functionality itself to start off is slightly lower than the rest of the population. And on top of that, every episode of illness, in this category, you will have cardiac disease patients, respiratory problem like COPD, congestive heart failure, or any neurological diseases will all come. Chronic disease, chronic multi-comorbidities, all those type of patients will fit into this category 3. So the important thing to see in that is, it will start off itself at a lower level. Is there a marker that I can use? Okay, no problem. We'll see if we can. So if you see the function, to start off itself, function is at slightly lower than what was there in 1 and 2. And every episode, anything like acute on chronic, normally, for example, any COPD patient you can take, they can have an acute exacerbation. So that is what is represented by each of the bumps in that graph. So when they have that acute episode, they are at one level, means by the time they have treatment and they are better, back to their normal, what they say, if you see, that one is not touching the function which was there when you start off. That is what I thought of marking. So if you say, if you see, for example, you mark that as, thank you. See, when they start, all of you can see where I'm marking, where I'm indicating. If one of you can.
Yes. Now we can.
So see, this is the starting point. So each episode, this is the first episode. Okay, after the episode, they've had some treatment, admission. Normally, they may get admitted also. After admission, so after admission and recovery, see, they come back here only. If you interpolate, it is here. It is not there. This is the take-home message I would love all of you to take. Because always, every time the patient or the family, they are back to normal. At least if all of you understand, then it can be conveyed. So this is natural process. We are not telling anything is wrong with anyone or anyone, but this is how the body responds. Okay. So to start off, it was here. They had the one episode, like one pneumonia infection is enough, severe lower respiratory infection. When they come back, they are not to their normal. So as I showed you, at least 5-10% is lesser. So like that, each episode it is coming down. So this is how any organ failure, it could be even CKD. You can take any system having chronic disease will have their acute exacerbations like this, and every time they come back, this is how. So they will not reach their original level, is what to be taken in. And organ failure is what today's overall, all over the globe, what is the common most seen medical issue means non-communicable metabolic diseases is the main cause of multiple hospital admissions or anything you see. Multiple comorbidities and multiple medical issues are due to these type of problems. Okay, and then the fourth one is frailty. In this is what you will see people elderly. In this you can have dementia or gradual natural aging process is what will come in this. Maybe even dementia and things can fit into this. But any other neurological disease will fit into category 3. So general senility, aging, those type of issues will come in category 4. See, in that fourth one, if you see, where is their functionality starting? Already to start off, functionality is low. When they are 85, 90, they will not be as they themselves would have been in their 60s or 70s. So in frailty, the functionality is very low, and it is a very, very gradual decline process. So these 4 is what to be known and understood well to move forward. Okay, next slide. Okay, now coming to, as I was mentioning, in the total end of life care, medical ethics is the backbone of it. Based on this only, these are what are going to help you to understand and make decisions whenever you are going to see patients in due course. So we have something called as 4 cardinal principles of medical ethics. First one is autonomy, next beneficence, non-malfeasance, and justice. We will see in detail about all 4 with cases so that you will understand what it is, and with the case examples, the clarity will also bloom along with it. So the main other 3 things which you have to understand along with this are dignity, honesty, and clinical integrity. To do that, what are all things what you're going to follow? Truth telling. You have to speak the truth. Even though truth and facts are hard to say, hard to believe, hard to be accepted, that truth telling is what will help you to move forward. Next, respect for life. You have to respect the person's life and give dignity. That's what is mentioned there also. Due respect and dignity is very, very important. Everyone has to have dignity until the last minute of their life. Why should they not get it is what we have to work towards. Next slide. We are going to see the first example. 78-year-old woman with stroke and hypertension and diabetes are the comorbidities. Basically, she is cachectic, bedbound, and dependent on someone for all her daily living, all activities of her daily living, ADLs. Then she's brought into hospital with reduced urinary output and reduced oral intake. And she's been diagnosed with UTI and end-stage renal disease. She is advised antibiotics and dialysis, but patient refuses. she says she doesn't want any further treatment, whereas the sons want her to undergo dialysis. So this is the scenario. Now we will take into consideration everything that is mentioned there. 78-year-old woman with what are her comorbidities? What is her basic performance status? She's bedbound and unable to do anything for herself. Okay, go on to the next. Now we will see. We'll try to get all your opinion so that we have an interactive session to get what is the idea you feel and what would you want to do. Will you advise the patient and coax her to have dialysis? You all can answer in the chat box or raise your hand or whatever is best for you. How many would like to advise the patient that she needs to have dialysis? Is there any response at all?
No.
See, either way, you can say yes, no, anything is fine, because we are here to justify and understand and make the decision collectively. Someone has answered no. Okay. No. Okay. Thank you. Next one, will you avoid talking and discussing the treatment with relatives alone? Some more said, okay.
We should discuss with patients.
Patient too, yes, exactly, very good. That is an important thing. Well said. And then rest two questions which are mentioned now. Will you respect patient's wishes? That's where she's coming to say that we'll have to explain and see what the patient wants. And will you refer her to a higher center? So these are the questions asked. I'll go on to the next one. So next we'll see in this thing, no? See, we will try to
She said need to discuss with patients as well as
relatives. Exactly. So coming to all the 4 questions, basically you have to first, our job is to explain her condition to her and then get a response from her whether she's understanding, whether she's able to comprehend. Just us telling the information and her not understanding or not knowing anything will not justify that we have conveyed everything to her. So we have to convey, we have to make sure she understands. She understands both the plus and minus, risk and benefit. What is that is going to happen if she has treatment? What will happen if she does not have treatment? What are the consequences? Everything has to be told to her and made sure she understands. And next, as you've all expressed, we have to explain everything what you've told her to the family also. We have to convey to both of them, make sure they both understand and move forward only on that. And then when you tell the pros and cons, you have to make sure that both understand. And if they have any queries, you ask them to ask and explain again. If they don't understand somewhere, then no point in us progressing. We have to stop there, ask them what is that they've not understood, clarify that, and then only move forward. So, and then next was that who makes the decision making there? Okay, whether patient tells one thing and family tells another thing. Because what was the query there? Patient did not want anything, but the sons wanted her to have dialysis. So, in this too, whose decision will you give priority? According to whom will you act? So here, that is what is explained here. We have to, as I was explained to you, as a doctor, we have to tell everything to the patient and family. And you have to give clear explanation, make sure they have understood, tell them what is ask their expectation, you tell what is possible, outcomes, everything you say, and then only as long the next thing, what does it say? Our duty and their duty is mentioned in the first box. Next one, you have to see whether patient is able to make the decision. That also is our responsibility to find out. That's why I said, you tell everything, ask them to repeat and say whether they have understood in their own words. They need not explain exactly the way you say, but they explain in their own words what they've understood. And you check the ability to understand. Is the patient awake, alert, is in a comprehending situation. So is the ability to understand their situation, ability to understand and appreciate the choices available. That's why I said risk and benefit. What are the pros and cons of having the treatment and not having the treatment? What will happen if you don't have, or if they don't have also, we have to explain. And then same risk benefit, and the risk benefit ratio has to be explained to them. And also to communicate their goals and aspirations. What is that we can do? What is that they are expecting? Explain everything to them and make everything clear. If the patient is able to make their own choice, at that point, you have to explain to the patient and the family that patient's choice will and should be considered. You tell them also in a nice way. We are not going to have a tug of war, having the patient relative and us having a fight, but explain everything to the relatives also. What are the pros and cons, and explain that the person or the patient has priority, and tell them also that if it was them in the place of the patient, what is that they would have liked. So if you explain in that condition, they will understand better. And then at that point, they may say, yes, if it was me, this is what I would have done. If it was you, and will you allow somebody else to take the decision? So those type of things, situations you have to create and show them. Next slide. So now comes this decision making or autonomy. How and when you will be able to get that right balance? Only when you give respect to the patient and patient has confidentiality and rapport in you. Day one, you come, ask, do everything. That may not be possible because this is a normal human tendency. That is why the patient would have been seen one doctor. So whether it could be the parent team or their regular physician, family doctor, someone. So like that, you also gain their confidence. And whenever you are empathetic and telling the truth, that confidence will automatically come. And next thing, as I said, you have given all the information. So that will throw more clarity for them. Their doubts, all queries will be clarified when you explain everything in detail. So that is why you have to take some time, explain everything to them and make sure. And if they have any cultural, religious beliefs, you have to respect that. You don't force your ideas on them. So that's what that collective autonomy is the norm in our culture. Yes, if that is so, that's why I said you have the patient, family, everyone together, convey the patient's wishes and choices, clarify the family's queries, and then it becomes a collective decision making. Still, the patient has the complete power. That is what is called as autonomy to make the final decision. Next one. So this is showing, like, even though you make clear ideas, it may be a tricky one, complicated situation, but you find ways and paths clearly, and then the decision making becomes easy. And then also you explain everything and make sure that they understand. Next. So see, there should not be any authoritative. Each one is an expert in their own way. So like that, there's no fault finding, pointing someone, all that doesn't happen here. Each one does their role in a proper way so that the correct person helps the other person to make the decision comfortable. Next. So giving respect is what is important, is to be upheld at all costs in medical ethics. So patient autonomy has a salient, important role. So next, in this itself, slightly tweaking the situation. Suppose the patient is not compos mentis, cannot comprehend, has dementia, lacks capacity to make decision, then what do you do? So to clarify this, we'll move on to the next element of ethics. So who is the surrogate? Then you find out who is the next of kin, or is there a nominated person, or is there any legal document already done? If any of the 1, 2, 3 is there, we will go one by one. If nothing is done, then comes in patient's best interest. That's what will be done. Or if, as I said, the legal, what was mentioned in legal is what given below is called as advanced directives. Either a living will or medical power of attorney. Living will is what many patients would have written when they are all right, when they were clear-headed. They would have made some decisions on what should happen if they become unwell or sick, or if they get to a state where they cannot exercise their power of attorney, or they cannot make their own choices. There are many things like that done, so they will write ahead. As that is why we all need to know that transition or trajectories. Okay, roughly from what we saw, only 10% have sudden death. Nearly 50-70% can have disease, ailment, chronic disease, all that we've seen. So nowadays, this option of writing in living will, making advanced directives are all very much possible. So many are adopting to this method. So sometimes something may exist already. When you ask, they'll say, oh yes, something was written and kept. So try to access it and find out. That will show so much light on you to make further decision. Okay, next. When patient autonomy is compromised, beneficence is going to be the guiding ethic. Okay. Beneficence is do good. So that is what it is. So always we are going to do everything in patient's best interest. Those are what is explained here. Obligations to act in the best interest of the patient. So trying to see, am I correcting all what can be corrected? Am I effectively managing the disease? What is the burden versus risk-benefit ratio? Simply, always everything has risk-benefit ratio. So you have to see the risk and the benefit and see which supersedes the other. So what is risk? How much suffering, pain will be there? Am I simply delaying the inevitable? What is the expected prognosis with or without treatment? And survival and disability, everything should be considered. And then if palliative is the best option, then you make the final decision. So all elements in this. So am I correcting whatever is correctable? Fine. Then am I doing everything in an effective way? Then risk-benefit ratio. If the risk is going to be more than the benefit, then should I do this or not? And another important thing is, am I simply delaying the inevitable? Anyhow, no positive outcome will come, but still I will keep on doing. Is that the way forward? So these are the important queries and questions should rise. And then with that, you're going to make a clear decision. Next slide. So for that, we will have another case. 20-year-old boy who has metastatic osteosarcoma of the lower end of femur with lung metastasis and anemia. Okay. And he has a large tumor on his thigh and insists on getting operated. Both parents and the patient are adamant regarding the operation. what should the surgeon do? I'll reiterate once again. Beneficence means doing good. So, and always have patience, like you do everything in patient's best interest. Whatever will be best for the patient, that is what we will do. So, in this situation, what would be the best way forward? Just as I said before, you can answer or convey your opinions either by typing in the chat or raising your hands or unmuting yourself. Either way, anyway is fine.
Ma'am, as the patient is having lung metastasis, the patient may not be anesthetically fit for the surgery,
Right.
such a big surgery, and surely after the surgery, the patient may not be having a benefit. So we have to explain these risks. If that surgery is performed, these are the risks that could happen to you. Like that, we need to explain to the patient and also the family members.
Joshna.
Joshna, very good. Well said. Exactly. That is our duty. When we say in patient's best interest, they may not know. See, for them, what they would have thought, oh, surgery is the way out. And that will correct my problem. So, well said. Our duty there is to explain things, explain the risk, explain the complications. So, risk outweighs the benefit is what is our job to tell them. And see, again, we have to explain to the parents also. See, parents are doing everything in love and affection. So, if the risk is so high, we have to explain what are the risks there and explain that he may not be able to survive the surgery itself. Already is anemic. It's a large tumor. That's why give importance to everything mentioned there. It's a large tumor. Already he is anemic. There is lung metastasis. And it's a metastatic osteosarcoma. So all this, it's our duty to explain. What should the surgeon do? Surgeon should explain everything as mentioned by Joshna to the patient and the family. And then give them some time. Don't force them to make any decision. Give them time to take in all what you have said. Because these are all really intense information. And patient, family, everyone are in a very, very sensitive, emotional situation. So at that time, you force them, explain everything to them, give them time, tell them you take your time, come back, I'll come and explain if you have more queries, and then we will move on. Next slide. So now the main thing that that was surgeon's job to explain everything and then only move forward. Next, we will see this. Through this, we will go into non-malfeasance also. Always we have to, same, what we spoke only is explained here. You have to explain the benefit, you have to explain the harm also. See, he has anesthesia, anemia, pain, all that is not going to helping. Debulking, they think that much. They think, oh, taking the tumor off might give him some benefit. He may be able to mobilize. That's what they will be thinking. But debulking is a big procedure. Will he cope and withstand all this is what has to be said. Now, click, it will come. So what else can be done? What are the options? And then also give clear clinical evidence. So anyone who has this extensive surgery we have figures generally to say, or whoever has multiple issues and has major surgery, the outcome or prognosis or outcome from the surgery itself may not be good, for which we have clinical data and number which can be explained to them. Next one. Also, request from family to withhold medical information. Say if they say something like that, we have to say, no, we have to explain everything to them. You can't hide things. So it is our duty to explain everything to them. conflict of opinion will be there. So that is where we have to have time, patience, explain, make them understand, give them time. Emotion overtakes sensible decision making. So, but when you give time and explain, you will be able to come to a consensus. Next. There can be even, see, as I said, like as it's mentioned there may be conflict within medical professionals also. There also, you have to raise awareness, explain everything to both, like it could be a doctor, nurse, anyone. So there, little bit more explanation, you have to show more evidence to prove what is right. Next. Okay, so here, next is, we should never do any harm. That is what is non-malfeasance. Non-malfeasance means do no harm. So under this, what all comes, you have to give respect and sanctity of life, or to the, as I said, to the patient or person all along. Non-malfeasance is the right of the physician. As we say, we have to do good, we should not do any harm also. That is also a basic right or basic duty of any practicing physician. And from this, what happens? We go on to the next one. See, there is something called as doctrine of double effect. So sometimes a treatment intended for good may unintentionally cause harm. So that is not an intent, because when I've said non-malfeasance, do no harm, immediately someone will come up. Oh, this one, when you did, you caused good and harm. But that harm was not an intentional harm. But that, for example, something like side effect could be mentioned as harm. So there you have to have clear clarification. Direct harm, and this is unintentional harm, which happens as a side effect. That is what is called as doctrine of double effect. So we'll see. And one more important thing is non-malfeasance overrides autonomy. So first we saw autonomy is what is the best. Here in this case, when we saw, the patient wanted surgery. That 20-year-old boy wanted surgery. But if he had had the surgery, he might not even survive and be alive. So if that's what is conveyed by this sentence, non-malfeasance overrides autonomy. So by telling and conveying to the person that the risks overweigh the benefit, and because we do not want to do any harm to you, we are respecting your wish, but we are trying to explain it to you. So that is what is meant by non-malfeasance overrides autonomy. Here I'm going to pause and make sure that all of you have understood what I've said here. If anyone has not understood, please stop me, and I am happy to explain this once again. We need to explain all disadvantages and advantages of surgery. Yes, exactly. That is what people have explained in the chat box also. But just I want to make sure, because see, medical ethics is something all of us have to understand very, very well. Because see, end of the day, none of us as medical professionals should have any burnout or some feeling that you have not understood whether have I done justice, whether have I done what I should do. That ill feeling should not be there with anyone, because we are all doing a job which is very intense, and you have to enjoy doing it and be satisfied also without any suspicion of whether have I understood, whether have I done it well. Those type of feelings should not be there, so that if that is not there, only your efficiency will keep on increasing and you will be able to provide an effective service. So if anyone has any queries, please do ask me. You can even unmute and talk. Because if so far everything is clear, see, silence to response only. Either everything is understood or nothing is understood. So at least for this statement, I would like to get a response. Either if it is the first one or the second one. Are we having a very good silent batch?
Only Vinisha and Jyotsna has
They were, yes. So they have understood. Understood. Okay. Thank you. Thank you very much. Because see, this is a little bit of a tricky topic only. Okay. That's why I am going in the slowest pace and making sure, see, it's English words, understanding everything properly. And you have to make sure so that if you have any query, that's why we are dealing it with cases so that with the case examples, it will make things more clear rather than having to assume and understand. Okay. So far we have seen autonomy, we have seen beneficence and non-malfeasance. Okay, next one. This is what is doctrine of double effect. So an example what is giving is performing salpingectomy in ectopic pregnancy is a very good example for that. A single act having two possible foreseen effects, one good and one harmful, is not always morally prohibited if the harmful effect is not intended. Okay? The action must be morally good. You must not desire the negative effect. And the good effect must be as immediate as the negative effect. Okay? And it all happens same time. But the first one or the good effect is what is intended. The second effect happens as I said, as part and parcel of it without any intention. Normal example is side effect. Okay. So here, for example, if the salpingectomy was not done in an ectopic pregnancy, the person, the mother or the lady will die, will never survive. It's a gynecological emergency, or obstetric or a gynecological emergency it is. So there, the person or the patient is our main, in patient's best interest, the salpingectomy is done. Okay, you can say by doing salpingectomy, the mother loses one tube and maybe her fertility may be affected. So that is what they come up, that causing infertility or taking the tube out was not the intended, there was no intention to do harm. But if you don't do salpingectomy, the mother would have not survived, mother would have died. So here only that risk-benefit ratio, this is such a nice example to understand the risk-benefit ratio. This risk-benefit ratio you can use in every act as you do. So if you use this and make sure that you weigh the risk and benefit and see which overweighs and then accordingly act. Okay, next slide. So we are going to see another example to see the last point of the ethics. A 57-year-old man with advanced metastatic cancer of the lung, severely breathless due to progressive disease. Whenever I'm explaining any such case, every line has some important word. And third one, all reversible cause of dyspnea has been ruled out. Admitted into ICU for artificial ventilation. What do you think about this decision? Here, salient points, I would say, advanced metastatic cancer lung. Severely breathless due to what? Progressive disease. Already advanced metastatic cancer. Then progressive disease is there. And then all causes of dyspnea have been ruled out. So correctable, all has been looked into. And then the basic disease process is not responding to anything. That is why it's progressive disease, not responding. And now he's admitted to ICU for ventilation. What would be your take? Is he an ideal candidate for ventilation? Yes or no?
Priyanka has said yes.
Okay, Priyanka has said that yes. So you say he should be ventilated. Is that right, Priyanka? You would say that he needs to be ventilated. Yes, okay. Anybody else?
Others, please respond. Nurses.
Krishna has also said yes.
Okay. Couple of them are telling no, yes, no, yes, fine. Yes, better to express and then we will discuss and move forward. Okay, go on to the next. I said that's all. So further more questions are, do you think he should be admitted to ICU? Should he be intubated? Should we resuscitate him if he arrests? Okay, here what we are going to discuss is justice or whatever. I'm going to tell this and then we are going to go into see one by one pros and cons of the decision making. What are the pillars on which the decision should be made? Whether are we utilizing the healthcare resource appropriately? Whether everyone is getting access to the resources. And next, the allocation of ICU source, is it made justly? Are we considering the family resources? Okay. Now we'll go back to that patient again. So see, first thing is that this 57-year-old man, can I ask people like who said yes, what made you say yes? No worries, right, wrong and all, we are not going to penalize anyone for anything. It's only a decision. So why did you feel that he is to be ventilated? Any one of them who said yes can say.
Ma'am, because patient suffer severity of breathlessness and this cause dysphagia is occur. In the ICU, patient supported for ventilation.
To correct his breathlessness, you felt that he will need ventilation. Correct?
Yes, ma'am.
Yes. Okay, thank you. See, that's what. See, that's what in the slide when we go to the third one, which we were next. See, we were trying to see correct his problem. Okay, but here main thing, from my point of view, like generally not my point of view, generally what you say, he's young, he's 57-year-old. That is one of the reasons where anyone and everyone may think maybe he needs to be ventilated. But in those situations, what is that we have to see? That is when, as I was mentioning, no, every sentence had some adjectives. He had metastatic disease. Go back to that slide which had all the see, advanced metastatic disease, not even just metastatic disease. When someone is having advanced metastatic disease, already the disease has metastasized to many organs. So there will be multi-organ involvement here. So he may be already in multi-organ failure. On top of that, this respiratory failure we are seeing obviously there. We don't know how his kidney functioning will be. The metastasis could be in the lung, liver, bone. So many systems are already affected. And the disease, it's a severely breathless due to progressive disease. His breathlessness, two possibilities can be there in this. Either the disease, primary, the cancer per se is progressing, and also his disease progression is so much that his lung might have had some disease which has also progressed. So he is breathless due to the progressive disease. That is why it is not the primary thing. The progression of the disease is one of the main cause for his breathlessness. So, and then reversible causes of dyspnea have all been ruled out. So 1, 2, 3 are all telling you that in spite of you putting him on a ventilator, he may not be able to come out of the ventilator. So next thing what I would like to explain here is whenever this type of situation comes, you think of someone, okay, I'm going to put this patient on a ventilator. What are the chances of him coming out of the ventilator? Ventilator is something which is going to assist. It is going to take over his respiration. Whenever someone is in this state, respiratory failure is also happening. Already advanced metastatic cancer will be affecting other systems also. So that is why you have to see his age may be a factor which may make you think that he needs full supportive care. But to make a decision of ventilation, you have to see the point 1, 2, 3 mentioned. Dyspnea, all correctable causes have been ruled out. And then disease progression is in such a state where he's not responding to anything. That's why it's, in spite of things, he's got to a stage where progressive disease. And the primary disease is an advanced metastatic cancer. For example, it could be a stage 4. Advanced metastatic cancer will be 3 or 4 stage. So that type of patient, is it right? I won't even say wise. It is right. Is it right to put him on a ventilator? So that is the first reason for decision making. Now go to the next. Now, after making that decision, you then come. See, this healthcare is, for example, a nice intensive care is there. I'm going to make this little bit more interesting. You get another 20-year-old, 20 or 30-year-old patient with pneumonia, who is fully fit and well, was working in his office till yesterday, comes into your ICU with same breathlessness, history, 3 days fever, and he's been breathless from this morning. You find out he's having some severe, highly infective pneumonia. You have that patient and this patient. And you have one ICU bed. Now if I ask you all to make a decision, what will you do? Here, see, don't think that we are discriminating. Okay? For all of us, all patients are the same. Healthcare, resource. You have this much resource only, but you have to give the best care. So in that case, who will be the ideal person to go on the ventilator?
For the person with the infective pneumonia.
Why?
Because he is having the chance of recovery. And
who is that
treatment
talking now? Who can I know who is speaking? Joshna. Okay. So basically, exactly, here you need not feel guilty. What can be correctable will always be correctable. Advanced metastatic cancer can be correct. That is, as we saw, something which is inevitable. Advanced metastatic cancer, can I bring him to no cancer stage? No one can bring. Okay, so here, self-guilt, all those things don't exist. So it's a medical decision. It is not any personal decision. No personal attachment to anything. It is just a pure medical decision. Josna explained very well. It's an infective, so it can be corrected, completely corrected once you give him antibiotic. There he needs ventilator. Why? Because the pneumonia, especially when pneumonia, anything happens in a 30-year-old, it will be a very, very potent pneumonia affecting nearly sometimes the whole of right lung. When you have 50% of lung, a 30-year-old cannot breathe. You give IV antibiotics, chest physiotherapy, ventilation, 3 days down the line, he can be extubated, weaned and extubated. 3 or maximum 5 days, something like that. You're using their ventilation option to tide over the crisis there. So they're managing or utilizing ICU resources in a proper way. That is like healthcare is, see, healthcare is a scarce resource, not only in India, all over the globe. Because healthcare cost is high everywhere. So we are making a we are making a sensible medical decision. That's all. Equitable access to resources. That 30-year-old and this 7-year-old, both, no discrimination, both are there. But someone will have a better outcome. Yes, someone cannot have a better outcome. I'm not making by my own choice. There are clear medical evidence to state that these type of patients' prognosis and outcome is all documented by some statistical and extensive research and data collection. None of these decisions are made on a personal or individual basis. Okay. So then that's what. Third, are we allocating the resource justly? That is what I gave this example. And then are we considering the family resources? See, next thing, this fourth one is very, very important. Okay. Little bit of explanation I will give. That same metastatic cancer person will not have a positive outcome, but you force them to put the patient on ventilator, 5 days ventilator, some 15-20 lakhs gone. And he has a 20-year-old son or daughter studying. So have you used the family's resources wisely?
No, ma'am.
So all these, see, that is where I would again and again tell, don't ever think of bring your personal or element into this at all. Make a decision on the overall. Stand back and make the decision. And no personal influence is coming there. It is truly a medical decision in the best interest of the patient. So next is patient and the family. Okay, that metastatic progressive disease cannot be corrected. Whereas his 20-year-old son can study, live, and look after the rest of the family at least. Okay, so these are all the medical decisions. So here this fourth point is justice or using the resources justly. That is also our responsibility. Okay, don't think that that is somebody else's responsibility. So if you don't do this properly, that is also negligence. So that is what is the fourth important pillar of ethics. Next slide. So fair allocation of societal resources. And these are some figures. End-of-life care consumes 10 to 12% of all healthcare expenditures. Physician's duty to an individual patient and to society as a whole may conflict in cases in which limited resources are disproportionately consumed by a critically ill individual. Assessing futility then becomes imperative. Exactly what is given here only, I have explained with cases, examples and things. Is that clear, or anyone has any different opinion, or you want to say something, please feel free. Okay, thank you very much. Okay, go to the next. So excessive aggressive medical interventions in terms of efforts and resources, exactly what we said only, should not be done. It should all be used only where and when possible. And that's it. Do not allow these things. See, for example, you go on and on, you end up having a patient who will end up needing more support, more help. even to what they are. For example, you end up having a comatose patient. What is the benefit? So that's what is being tried to explain. Next slide. Next, these are a few things like if there is something, if some treatment is not going to be beneficial, then you come to a state where to withdraw or withhold treatment. Okay. So in that case, for example, rather than going into ventilating situation, you can make a decision of because the disease progression is got to a stage where it cannot be reversed. So then you think of palliative management. So now from only palliative management is the only option available. Okay. And in that situation, sometimes withholding treatment or withdrawing treatment, both are the same. No ethical difference between withholding and withdrawing. Basically, what you do, you just continue to do what is basic sustainable thing required. You don't add on additional care or treatment options. So in that we will, that CPR I think comes in the next slide. So is it legal? Or some people have a doubt, withholding, withdrawing, is that itself, is that euthanasia? No. Okay, next slide. What is the difference between withholding and euthanasia? So euthanasia is not a passive action. It is a deliberate action. It is not allowed in many parts of the world, but for only 1 or 2 places. So don't ever confuse euthanasia with withdrawing or withholding. Withdrawing, is we are not continuing to do like antibiotic and intervention, ventilation. That is what you're not doing that and stopping. No, that is withdrawing or withholding. Whereas euthanasia is completely opposite. It's a deliberate action. It is not legal anywhere. It is illegal in India. So all that has to be understood clearly. And withholding and withdrawing life support in a patient with terminal illness or nearing end of life is not euthanasia. So that's what you have to understand and have clear information on. Withholding, withdrawing is different. And I've explained to you what it is. So don't confuse that with euthanasia. Next slide. And next, what we are going to see, some of the legal things what are available. Okay. The recent Supreme Court judgment is the right to die with dignity is the fundamental right of every human being, as already declared by the Constitution. And we declare that an adult human having mental capacity to take an informed decision has the right to refuse medical treatment, including withdrawal from saving life devices. Like this defib, nowadays you have implanted devices, pacemaker, defibrillator, all that it is individual patient's choice. You cannot force anyone. No, I will correct my word. Not you cannot, you should not. Your duty is to explain. Then final decision making is theirs. If they say no, you can't force them until you have to have it. Okay, there you are impinging on their autonomy. An adult human being of conscious mind is fully entitled to refuse medical treatment or to decide not to take medical treatment and may decide to embrace death in natural way. That is their right. Okay, next slide. So next we come to this advanced medical directive and living will. See, this is available everywhere in the world, and in India also, January 2023, legally orders have been passed. So anyone and everyone who is able, like he is compos mentis, who has the comprehensive ability, can make this decision. In this, it is called as a living will or advanced medical directive, in which you can mention everything, like what treatment you want, what treatment you don't want. Like, for example, I don't want intravenous, everything can be mentioned. I don't want NG tube put in, even if I get to a stage where I cannot eat. Because see, if you are very clear, at least people will not force anything on you. So it's an individual's advanced exercise of his autonomy on the subject of extent of medical intervention that he wishes to allow. upon his own body at a future date when he may not be in a position to specify his wishes. The purpose object of advanced medical directive is to express the choice of a person regarding medical treatment in an event when he loses capacity to take the decision. Next slide. So the various legal document, it's a legal document created by patient and explaining and documenting their wishes about what treatment they want. And if they, that is when they become incompetent, that's what as it mentioned, no, now they are okay, they are writing, because in advance thinking or anticipating that if they get to a stage where they are unable to communicate due to terminal illness, not necessarily, they may wish, they may even be able to comprehend, but they may, for example, some stroke may come and they may not be able to talk, but they may be very clear in their head. If they are not done this ahead, they may not be able to get that self-respect and dignity. Okay, and this guides the medical profession and family about medical care. That last is also a very important thing. It's beneficial for the person or patient, beneficial for the medical society, and for the family too. Because family need not feel bad that they did not do or they did. Both things are not there. Next slide. So, and then these are all not just done very casually. Okay, a full big team of experts participate in making these type of legal documentation. So no one needs to have any finest or slightest query also in this. And one more thing, just like a completion type of thing, what I wanted to add on was, like whenever someone gets to this stage, whenever you have or studying about end of life care, sedation at the time of end of life care also is part of it. And from that point of view, many clear policies are there in institutions. So you need not worry about it, because it is always better to follow policy, because what are the benefits of guidelines and policy? It is clear cut, no queries, it is streamlined, it gives you what to do, what not to do. So you just follow those guidelines and less or no harm will be there, and it is generally easy to practice. And normally there are specific sedation guidelines for end of life care, which will have medicines to allay anxiety, to allay the respiratory distress, to keep them calm and comfortable, so that both the patient or person and the family, both their distress is taken away. So that sedation is also part of it. But as generally everywhere, every institution has their own policy, and better to stick to that policy. If there is no existing policy or anything, then get in touch with Pallium. Pallium will be willing to help you and guide you with how to follow one such policy. So with that, we will come to, so, and main thing is that all this, is that the, and that's the last slide. And so that is what it is. So few, like a nutshell or take home, what I would say is, the medical ethics form the basis of end of life care. Okay, autonomy, beneficence, non-malfeasance, and justice or justly utilizing the resources. These form the 4 pillars, and within that you have to be honest, maintain and give due respect and dignity for the patient. So all these together is what will help you to deal with the end of life care situation correctly. Thank you very much. Anybody has any queries or doubts, please go ahead.
You can use the chat box and unmute yourself.
Is there?
Yeah. Thank you, ma'am, for the wonderful session. As ma'am requested, if anybody have any questions or comments, please. You can unmute yourself and talk, or you can put your questions in the chat box. Okay. Yoshna said everything clear. Thank you.
Krishna.
Okay. Others? Priyanka said clear. Okay.
See, this topic is like anyone working in palliative care already? Can I take it as a no?
Please respond in the chat box, please.
If anyone is working in palliative care already.
Yes, ma'am. Ganesha
Ah.
said yes.
Yes.
Ashwati said yes.
Oh, very good. So do you have policy and guidelines in the places where you're working?
Yes, Priyanka said yes.
Okay. Where, if I can know, Priyanka, where are you working? Someone has said no also.
Yeah,
Sindhu. Priyanka Chandra.
Priyanka said
Vaijayanti Deshpande.
Yeah.
Vaijayanti Deshpande, well, are you also working in a palliative care setup? Yes, okay. Good, that's what. Because why I was trying to say is better to follow guidelines, what is there in your setup. And if you have any queries, I would say you could get in touch with Pallium because they have a very streamlined guideline and they may be able to help you to follow it in your setup too. Because see, these are very stressful and sensitive situations, okay? So that is why following a guideline will be better. There will be no discrepancies between all the staff who work together and taking care of the patient, carer and the staff is also our responsibility.
Okay, ma'am, thank you. Can I add something?
Yes, please go ahead.
Okay, ma'am has covered almost all the points, but I would like to highlight few nursing aspects, especially in end-of-life care, because in end-of-life care, patient need more care because nurses are the only one person to take care of the patient if it is an end-of-life care. So especially one of the most common problem in end-of-life care is death rattle. So this will be affecting the patient, which will not be affecting the patient a lot, but it will be affecting the family a lot because they will be thinking like, okay, this sound will be because they are not able to swallow their own saliva properly. That saliva pooling in the lower throat, and then when they the respiration, so when they breathe out and in, so they make some sounds. It will be creating the problem to the caregivers. They will be thinking like this will be affecting the patient breathing pattern and all. The patient is in the breathing difficulty. That kind of thought will be there. So what you can do is you have to give a proper education for that, and reassurance is very, very important there. And also you have to do some nursing care. You have to keep the patient in right position so that all the secretions will drool out and provide mouth care. That all things you have to keep it in mind. And if the secretion is that profuse, then you have to think about the pharmacological management like glycopyrrolate or buscopan or even atropine also. But we usually prefer glycopyrrolate. You can use sublingual or you can give a subcutaneous or intravenous, whatever way you can use that thing. And another important thing is nutrition and hydration. So that is, ma'am has explained very well. If the patient is in end of life care, they are not able to talk clearly because say you can just think about a semi-conscious or an unconscious patient. They are not able to talk. But the caregiver has requested you to put sterile tube or intravenous fluid. That request will be there. So what you have to do is we are the person to advocate for the patient. So that is one of the role of palliative care nurse. We have to think from the patient side and you have to educate the patient caregivers first. And you have to understand their concern because food is a symbol of love. So they all are interested to give some good food for their loved ones. Because even if the end of life care situation also, they prefer that. So they are they're willing to give some kind of nutritious food to their loved ones. Because that time, what you can do is you have to talk to the family members, sit down and call a family meeting and address their emotions and they listen their concerns, and you have to make them understand it will not help to their loved ones. So if you give some maybe TPN, total palliative nutrition, that will be helping to the disease, because if there is a tumor there, the tumor growth, that nutrition will help to the tumor. It will not help to the patient. If you give these kind of food to the patients, that creates some other problems because the lot of secretions will be there. Then the patients will have breathlessness because pulmonary edema will be there because of the fluid overload. These kind of things you have to educate well, and also you have to, if they request you to put a rice tube, how to make them understand what are the procedures, what that distress are going to face your loved ones. And after that also there are some complications, aspiration pneumonia, bleeding. There are a lot of problems. So these all things you have to explain well, and after that they will understand about the good and bad things, and they will. So that is very, very important. So we are the person for advocate to advocate for the patient side. So these are two things I want to highlight. Ma'am, do you want to add anything?
No, definitely. See, from what you said, Shiva sister, it is really true. It's our duty to explain, and especially this death rattle, what she said, we have to explain to the family that the patient will not feel anything. Okay, so it is more of a distress to the family around. And also nutrition, we have to tell them that just that IV fluid is not going to correct the problem. By giving IV, they may get more fluid intravasation, more pain may be inflicted. So that's why again and again, it's our job and duty to explain things to them. See, not everyone will know everything, and they need not know also. So, for example, I'll say, I won't know everything A, B, C, D to Z of computer science. Okay. So, like that. And all of us are not experts in everything. So, that is what to be considered, and our duty to explain to them. Once you explain to them, then they will see. So, for example, IV fluid, because everyone thinks give IV fluid, especially in end of life care, IV fluid is not what is to be given. They will already, IV access will be very bad, and you'll be poking them, trying, and then fluid extravasation everywhere, bulges will be there. That will cause more pain. So if we explain all this to them, then they'll say, oh, no, we don't want to impact. And that is not going to help in their outcome. So more of our responsibility to convey the correct message to them And nursing issues, what Shiva has mentioned, has to be kept in mind. That is also, as I say, no, these are all our duties. We cannot go wrong in this and should not go wrong.
And also, you don't forget about the family. They are going to lose their loved ones, so they will be in very distressed situations. You have to understand their emotions and give a psychosocial support to the patient family. So that is also important. And from the palliative care day itself, that session, the first day itself, you learn palliative care never stop when the patient dies. You have to continue the care as much as they need, because the bereavement support is also there. You have to call if you are able to go and visit the patient family, please do it. Otherwise, you have to make a phone call and understand their just talk to them, and you have to give some psychosocial support through phone at least.
I was also about to say the same, Shiva. Bereavement is part of the next thing. Whenever you think of end of life care, bereavement also comes, and palliative care, any palliative care setup, do have a bereavement support team, and that can vary. For some people, bereavement like grief. Grief again is very variable. For some short-lived, for some long-lived, 6 months, 1 year. So at least our bereavement support will go on for some time. And if it's a very young family or something, how can you help them to get back on their feet? Is what also part of the palliative care team. As much as possible, we cannot go and correct and rectify everything in the world. So something what could be done in the immediate time after the passing away of the patient should be tried and attempted. So that also, as she said, and then nowadays, I think all of you would have known, definition of palliative care itself includes patient and the carer. That's what is the definition of palliative care itself. There's no, like if you're providing care, it is the patient and the caregiver together.
Okay, ma'am.
We'll
So
have
I think, yeah, okay. So today it was a wonderful session because ma'am has explained very well with the patient story. We don't have a patient story today, but madam has come with a patient story. But so it was a very understanding the session. So thank you, ma'am, for the excellent session. Thank you once again for others for your contributions, and thank you.
Thank you, one and all. Good wish and good luck to all of you to practice whatever you're going to do.
Okay, thank you everyone for participating. I believe everyone understand what she really said. She explained well with each topic with the case also. She was also added the basic nursing issues we have to face with. Thank you, Shiba ma'am, for that. And thank you everyone, especially Joshna Chandra, for participating very well and making it an interactive section. See, we have rescheduled our basic nursing issues topic on Monday onwards. Let's see you on this next session. Thank you. Bye, everyone.